Chapter 29, The High-Risk Newborn, continued. RDS in the premature infant is caused by insufficient amounts of surfactant in the lungs. Remember, the surfactant is what allows the alveoli to stay open during expiration. If they do not have the ability to stay open, they become stiff and they do not want to expand during inspiration, causing respiratory distress. Manifestations will occur within the first hours after birth and can include tachypnea, nasal flaring, retractions, and cyanosis. Grunting also can occur as the body is working to keep the lungs open at expiration. Breath sounds may be decreased and acidosis can occur due to hypoxemia. Surfactant replacement can be given via an ET tube when RDS is confirmed. Other things is CPAP or mechanical ventilation, oxygen, correction of acidosis, IV fluids as well. Also being aware of thermoregulation issues and correcting is needed. The nurse must use good assessment skills at birth and then after to monitor for changes in the infant status, monitoring labs and watching for signs of sepsis. Intraventricular hemorrhage, IVH, is bleeding around and into the ventricles of the brain and can be caused by increased or decreased blood pressure, asphyxia, or respiratory distress that required mechanical ventilation. A few other causes include rapid blood volume expansion, acidosis, and hypoglycemia. It is graded 1 to 3, and with 1 being very little bleeding. Some infants show no signs, while others will have lethargy, poor muscle tone, respiratory status worsening with cyanosis or apnea. They can have seizures. It's diagnosed by ultrasound and in most cases occurs in the first 7 days of life, so an ultrasound is typically scheduled at that time. Treatment is supportive measures of the manifestations. Nursing considerations include trying to prevent an increase in that cerebral blood flow, so trying to avoid those changes is important. Even crying can cause, so trying to avoid those as well. Be alert to signs and complications, daily measurement of head circumference, and watch for signs of neural changes. Retinopathy of prematurity, ROP, can result in visual impairment or blindness of the preterm infant. It occurs from injury to the retinal blood vessels. They're not sure the exact cause, but one risk factor is high volumes of oxygen, but some infants still will develop this that never receive supplementary oxygen. Immature blood vessels of the eye constrict and they're obliterated. New vessels proliferate through the retina and into the vitreous humor in some infants. Fluid leakage and hemorrhage can cause scarring, traction on the retina, and retinal detachment. Management includes screening infants born less than 30 weeks or weighing 1,500 grams or less at birth, and those with birth weight of 1,500 to 2,000 grams who are unstable at 4 weeks of age or at least 31 weeks gestation. Laser surgery is a current treatment of choice. Nurses should monitor pulse ox frequently. Explaining to parents the ophthalmological test. These can be stressful on the infant, so using comfort techniques such as swaddling can help. If surgery is needed, good assessment skills for signs of complications will be needed and support provided to the parents. Necrotizing enterocolitis, or NEC, is a serious inflammatory condition of the intestinal tract that can lead to necrosis of the intestinal mucosa. The exact cause is not known, but immature intestines is a major factor. The earlier gestation, the higher risk for the infant to develop this. Feedings that are too early or too fast is thought to be a major cause of NEC. Bacterial colonization with pathologic organisms can be present. This can lead to necrosis, perforation, and peritonitis. Breast milk may have preventative components, so is always encouraged. Manifestations include increased abdominal girth, which is caused by the increased gastric residual. They will have a decrease in the bowel sounds, the visible loops of bowel, vomiting, abdominal tenderness, erythema of the intestinal wall, blood in the stools, and signs of infection. Respiratory difficulty can occur due to the increased pressure on the diaphragm from the distended abdomen. Apnea, bradycardia, temp instability, lethargy, hypotension, and shock may also be present. Therapeutic management include probiotics, which is being studied right now for their effectiveness. Antibiotics will be started and feedings will be stopped. Gastric suctioning may be needed and IV fluids. Surgery will be needed if the condition worsens and an ostomy will be placed. Nurses should be encouraged all moms to provide breast milk to decrease the incidence. Good assessment skills are needed. Abdominal girth measurements will be taken daily, IV fluids, and parental feedings. I's and O's will be needed as well. Post-term infants are those born after 42 weeks gestation. The biggest risk is the placenta no longer functions properly. If there is placental insufficiency, oligohydramnios, which is low fluid, can lead to cord compression. Remember, you will see that on the monitor strip as your variable D cells. These infants, if not receiving the nutrients, may be small for gestational age. This can lead to hypoxia and malnourishment and is known as post-maturity syndrome. They are at high risk for having meconium fluid due to the stress on the fetus. After birth, when doing your assessment, you may find these infants with loose skin and little subcutaneous fat. There's a decrease in the vernix, but typically they have more hair on their head and long nails. The skin may be wrinkled, cracked, and peeling. They may have a low temp due to the loss of the subcutaneous fat. The nurse will note signs of post-maturity syndrome. Respiratory issues may be present to determine measures that will be initiated. They are at risk for hypoglycemia as well, so monitoring blood sugar after delivery is protocol in most facilities. Monitor temp for any instability is needed as well, and if problems occur, provide interventions as discussed earlier as needed. Small for gestational age, or SGA, are infants who fall below the 10th percentile on the growth charts. These infants are also called fetal growth restriction, FGR infants. These infants are subject to many of the same issues as preterm or postterm infants. They may have low APGAR scores, meconium aspiration, and polycythemia. Hypoglycemia is common due to inadequate glycogen storage in the liver. They are also at risk for ineffective thermoregulation due to a decrease in their subcutaneous fat. The infant can have systemic growth restriction or asymmetric growth restriction. Symmetric growth restriction involves the whole body. In asymmetric restriction, the head is normal size but seems large for the rest of the body. Length is normal, but the weight is below the 10th percentile. Therapeutic management includes prevention by encouraging adequate prenatal care. Care for the SGA infant must be individualized to the issues that the infant is displaying. Large for gestational age, or LGA, is an infant over the 90th percentile on the growth charts. They may have macrosomia, which is larger than 4,000 grams, and usually are born at term. The LGA baby is likely to go through a longer labor, have injury during the birth process, or need a cesarean. Shoulder dystocia can occur, and if it does, check for fractured clavicles. Bruising is more common, and so are congenital heart defects. Therapeutic management includes identifying these infants by accurate fundal measurements at the prenatal exams. Nursing considerations include assessment for any injuries that have occurred. They are also at high risk for hypoglycemia and polycythemia.